Hi, Smart News. Welcome to your Tuesday town hall. I'm so excited about this. I'm excited to talk to Dr. Rutland again. And I'm also excited to try to make journalism work for you again, which is really what our goal here at Smarter News is all about. You know, town halls, call-in shows are as old as time. Why do they work? Why do I want to embrace this sort of format? Is that the goal of a journalist is to get your questions answered. It's great if I can get my questions answered and I'm building upon reporting that I've done over the last several years. That's great. Hopefully I can add more to the conversation when I report back to you. But fundamentally, my job is to get your questions answered. And this is a direct way that we can connect to a reliable source and talk about one of the biggest stories potentially of our lifetime. Let's just knock on wood because we know the future is uncertain. We have to look at things with some humility. But this is why I think a town hall is important at this critical period. Here we are 18 months into a pandemic. We're yet at another juncture we maybe didn't really think about, heading into the fall with the new variant, and reflecting on what our lives all look like. So we're going to be talking to Dr. Rutland. I have a list of questions, and as most of you kind of jump on here, and some of you are joining us later, I just want to mention something else. One of the issues with journalism isn't just about delivery, it's also about tone. And this has been an extremely confusing period. I know you have a lot of information coming at you. I have a lot of information coming at me too, and I feel I'm confused on all sorts of things with my life. So when you send me questions, I just want you to know I love you guys, I care about you, and I want the best for you, and I'm not looking at any of your questions with any sort of judgment. So I don't want you to be afraid to send questions in. I want this to be a place you can ask them because you might see things on the internet that sound pretty good and you don't know who to trust. And I realize that. But I always think about journalism right now and the state of journalism sort of being like a fancy restaurant in New York City where, you know, you walk into this fancy restaurant and the waiters are kind of like looking at you like, what do you know? Here's what you should order. I want Smarter News to be like the cool hamburger diner in your town that you come, you always feel comfortable, you know we're going to take care of you, and we're not judging you, you know? And that's part of the reason why I think we've been able to grow to include such a diverse audience. You guys have a lot of different perspectives, and sometimes you have the loudest voices on both sides yelling at each other, but you have a bunch of people in the middle. So I want to talk to everybody, and so that's why I'm really excited about today. So let's go ahead and make sure that we can get Dr. Rutland in here. I want to see, Dr. Rutland said that he's in his office. So Dr. Rutland, we're inviting you in to see if we can get an update on that. In the meantime, are you wearing a suit today?
I got dressed up for this today.
Come on, this is amazing.
I did. I did.
This is good. Okay. I mean, I don't mean to act surprised. I know you have suits in your closet. I just didn't, you know, that's for you. I decided
to look official today.
You look great. And tell us a little bit, this is the new office with the shoe wall?
Yeah, so we, you know, my wife knows I have a love for sneakers, and what she decided to do was to create a place where I can display them and to get them out of her side of the closet. So in the process of doing that, we turned the guest room downstairs into an office, and it's more of like an office / studio where I can do all the things like this in addition to displaying my sneakers. But I've already run out of space, so.
So, I mean, one of the most burning questions I have now is, what are you doing for her? If she was able to do this, what is her closet? I'm just curious.
So the Rutland household. She has basically most of the closet upstairs in the bedroom, of our walk-in closet up there. She has most of that. And then I just took my shoes and moved them down here. And then I have all my suits and all that. And then I have all my clothes like in a drawer and on some shelving. So
there you go. This might be a really important point. I think you might be one of the only doctors in America talking about the new coronavirus with a shoe backdrop. So you're unique for a few different reasons. You also, just in case anyone's new to you and your work, you're a pulmonologist. Yeah. You really study immunology. You work in the ICU, so you care for actual COVID patients. That's important to point out. A lot of people in the airwaves don't actually care for COVID patients up close, and you've seen it up close. So you study, you research, and you also can see it
in real life. What are you seeing right now? Before we get into some of the questions, because you've spent a couple of days just recently in the ICU, you've been working some long hours. What are you seeing where you are in California?
There's definitely an uptick in cases. I'm seeing some good things, some bad things. The bad things I'm seeing is the uptick in cases and people getting into the ICU. And the people in the ICU, unfortunately, they are mostly unvaccinated, right? I mean, in our ICU, it's 100% unvaccinated. In other ICUs in the county, it's about 86 to 90% unvaccinated. And that's the issue.
And that's the issue. Is there any other trends to the people that are in the ICU? Are they, do they have pre-existing conditions? Mm-hmm. Are they overweight? Like, are there other things that we should also know about besides their vaccination status?
Yeah, when you look at those people, I can tell you this. I can tell you that they're probably on average 10 to 15 years younger than they were during our last peak in about December, January or so. So that's kind of scary. So some people have conditions that they didn't know about, but most people don't. Most people are just general healthy people who happen to get infected and develop life-threatening sequelae secondary to the infection.
Quick other question on that. How are people, when they're coming into the ICU, because one of the things that has been scary about this is that we don't know who gets most affected, like who's going to develop the more serious reaction if they get the virus that causes COVID-19. Is there a point when people know they have to go to the hospital? Like, what is the tipping point for people when they come in? Or is there any sort of advice you could give to people? Because it seems that these folks that you're describing, some of them wouldn't expect to wind up in the hospital. But I don't know if I would know, hey, I actually need to head there. Is there any information you can give us on that?
Here's a key thing. So again, as you mentioned earlier, I'm a pulmonologist and I take care of a lot of different people, right, with lung problems. I see coronavirus from the very beginning. I see it at the very end. I see it in the middle in the ICU. And to be honest with you, I don't know how many people have that kind of experience, have that broad of an experience, and are able to articulate it and talk about it in the way that I do. But I'll say this, when you look at people who are presenting with infection, people just don't know. We don't know who's going to get really sick and who's not going to get really sick. We have no clue. And so what I tell people is, listen, if you know me, if you're my patient, if you're around me, if you have my phone number, as soon as you're positive, call me. Because I think that communication strategy is what can help people the most. Because in my mind, if I'm giving advice, in my mind, and I tell everybody this, once you're positive, go get the monoclonal antibody. I don't care existing condition or not.
You said as soon, no, it's actually, what's funny? Can I actually tell you what's happening right now?
What's happening?
My doctor's calling me and I haven't talked to my doctor. Like you're talking about talking to your doctor and the doctor is calling. I don't know, maybe she heard something. Maybe she's watching.
That's good communication. That's good communication.
But you were saying you should basically communicate with your doctor if you have a positive test, even if you feel fine. But I believe you were going to what you believe is the treatment that everyone should know about and should be asking about at this time.
Listen, there's going to be academic people, and I'm an academic person. I mean, let's be real. There's going to be academic people who may disagree and say, oh, that's not the guideline. But listen, if you're positive for SARS-CoV-2, you need to go get monoclonal antibodies. And I mean the day you're positive. We know that therapy prevents hospitalizations, likely prevents death in the long run, right? Because what it does is it neutralizes the infection. So it doesn't allow the infection to overwhelm the inflammatory response. So the inflammatory response is like, oh, that's taken care of. I don't need to inflame. And so I tell all my patients, and I can't tell you how many people have messaged me saying, thank you so much for telling me about going to get monoclonals. I really appreciate it. I think it really helped me because I didn't have to go to the hospital or stay in the hospital. And I feel like, I just feel like that is the appropriate thing to do for humanity in general.
So interesting. So one of our viewers, E. McFall, is saying, well, how and where do I get the monoclonal antibodies? Mm-hmm. Alicia's saying, why did doctors say just go home? We can't do anything. And then we have another person that's here that says, hey, those monoclonal antibodies actually saved my boss's life. So if you call a regular physician, is this something that they're going to be able to help you with? Do you have to go to the hospital and say, hey, listen, like, this is what I would like?
Right. I go to the hospital, advocate for yourself, number one. But number two is, this is really number one. There is a website on HHS, CMS, where you can get these monoclonal antibodies and where they're located in your zip code. So if you go to that website, I think it's hhs.cms, just type that in, HHS, CMS, monoclonal antibody therapies. And I believe based on your zip code, they can tell you which hospitals they have been allocated to and where you can go get those therapies. Now, you're going to have hospitals that are really strict with therapy. They're going to say, no, it's only for people who are over 65, people with hypertension, people who can't generate an immune response to the infection. Now, although I heavily disagree with those statements, there are rules. And the EUA has that in the EUA, in their emergency use authorization. It has these rules. I will say this, people that can't mount an immune response to the virus, that are just merely exposed to SARS-CoV-2, meaning they don't even have the positive test. They're just exposed. One of their friends tested positive, they went to dinner with, something like that. They are now able to go get monoclonal antibodies. So it's almost like an exposure thing. And so I'm going to tell you this, there is no difference between those people who have these conditions and normal people. I just don't see it. I just don't see it anymore. And so, again, I'm a physician. I advocate for patients. I advocate for family, friends, people, yourself, your husband, whoever. I will tell those people, go get monoclonal antibody therapies. And my ER in the county that I'm in, I know that they're passing it out. I know that they're giving it almost to everybody. And so telling people to wait until you're sick is just bad advice now. It is bad advice. It was bad advice from the very beginning. I always thought that. And it's bad advice now. It is horrible advice.
So Lisa Marie's asking, what antibodies, is there something specific to ask for, and how exactly do they work? You mentioned that your body doesn't freak out as much because it's the freak out that's causing the real kind of, if I'm using, of course, my terms, doctor, you'll use better ones, but it's the freak out of the system that's making you very, very sick and kind of in this cycle that you can't get out of, where you're finding that patients are getting sicker and sicker. So what exactly does the monoclonal antibodies do to disrupt that?
Okay. So you know me, I'm a teacher, and I feel like we've been doing a lot of telling, and I feel like the most important aspect of any pandemic is teaching. So we're going to teach for just a minute, so bear with me. We have to understand the way the coronavirus looks. We know the way the coronavirus looks, not only because of the SARS-CoV-1 epidemic in 2003 and the MERS-CoV epidemic in 2006, which are also coronaviruses, but we know the way it looks because coronavirus causes the common cold in like 33% of adults, all right? So this virus has been heavily studied. So the structure of the virus is as such.
Can I show you, can I pull up a picture and put it on the screen while you're talking? And that way people can just look at this instead of looking at me and kind of visualize what you're saying. And this is I love the colors in this particular.
Yeah. That's a great picture.
Okay,
now,
go ahead.
What you're seeing in that picture, if that pinkish purple circle is essentially the virus. And then what you have on the outside, all of those, the yellow, the orange, the green, those are all the structural proteins of the virus. Now, this virus encodes 29 proteins in total, but 4 of those proteins are structural proteins, meaning they're on the cell membrane of the virus. We're talking the nucleocapsid protein, the spike protein, the envelope protein, and the membranous protein. The way that we are describing this virus to the public, when you hear this term variant, or you hear this term mutation or whatever, what people are actually referring to is the spike protein. The spike protein is most important because that's the protein that binds to all of our cells. That's the protein that binds to the endothelial cells, the cells that essentially line the respiratory tract and line your GI tract. Those are endothelial cells. So the spike protein binds to the cells. That's how it enters our cells, is with the spike protein. Okay?
Is that the spike protein?
Probably the yellow is the spike.
Probably okay.
Yeah, that's the spike protein there. So the spike protein consists of building blocks, right? Or bricks when you're building a house, right? Every brick is a different amino acid. Amino acids are what build proteins. Now, when you build this house of spike, right? You're building you're using these amino acids to build the spike protein. It looks a certain way. So what's a variant? A variant is when a couple of those amino acids switch. They turn to a different type of amino acid. It can change the shape a little bit, not the function, but the shape a little bit. Antibodies recognize shapes. They recognize amino acids. They recognize where the amino acids are placed. And once you are infected with that you can see, your immune system gets notified of this infection. How does it get notified? Your cells take up the virus. They split the virus into little pieces. And then they display these little pieces on their own cell membrane for the immune system to get recruited over and recognize different aspects and different pieces of the virus. So when you're infected, you're going to generate antibodies and cells that recognize spike, membranous, envelope, nucleocapsid, and some of the open reading frames of RNA, some of the other non-structural proteins that are encoded by the virus. So you have this plethora of cells that recognize many different molecules that are located within this virus. That is how your immune system recognizes infection. That is what most people would call natural immunity. Now, the variants basically are different spikes, right? The amino acids change. And so what can happen as those amino acids change is that spike protein can kind of sift through things a little bit, almost undetected, right? So the spike protein kind of sifts through, can bind to the cell even tighter, and the tighter it binds, the more activated the inflammatory response is, right? And if it can do that, it can also replicate easier. And so what you're noticing with this Delta variant that everybody is hearing about right now is the Delta variant seems to have more of an abundance of itself within the body. So example would be a wild type coronavirus or a traditional coronavirus. There might be one virion. With the Delta variant, there's 1,000. So it's 1,000 times more prevalent, like in your body. So what does that mean?
So I want to ask you about that, what it means, but for Delta variant, if let's say this spike protein is slightly different, can you easily see it? You know, if you were looking for it, can you easily tell when someone has a virus that is Delta versus the quote unquote, you know, new coronavirus that we had a couple, 6 months ago that wasn't Delta?
You have to sequence it. So when you sequence it, you're looking at the spike protein and you're checking the placement of the amino acids. And that's how you know if it's Delta or not. Now, does that happen in every single person that's tested? No. But in 80% or 90% of the specimens that are tested now in which that does happen, we do test for it, it's Delta variant. So that's how we know which coronavirus is spreading.
Okay, so you were saying with the Delta variant, one of the things is that you just carry so much more of this virus than other variants. And you were going into why that really also matters for us to understand.
Right. So when you carry more virus, right, when the virus is replicating faster or there's more of that virus in there, what do you think is going to happen, right? It's just kind of like if you have more people at a party, the party gets louder, right? So it's the same thing here. If you have more virus at the party gets louder, meaning the immune system gets more activated. And that's why these people get more severely sick, right? And so that's the issue that we're having, especially in people who are unvaccinated, right? Is that.
Okay, so let me just pause you there for a second. So if you have the antibodies or the antibody treatment, and we're going to get into a little bit of natural immunity as well, but getting to that monoclonal antibody treatment, if the antibodies are recruited like a little army, when they know what they're looking for to kind of help your body not overreact but fight off this virus, then how are the monoclonal antibodies effective against this variant as well as others? Do we need specific monoclonal antibodies for Delta versus another variant?
What a great question. So with that question, what you hear is the appreciation for variants and the appreciation for different amino acids that make up the spike protein. So we tested for all this, right? So the monoclonal antibody therapies that are out now, so there's one by GSK called sotrovimab, and then there's another one by Regeneron called Regeneron-CoV. It used to be Regen-CoV 2, now it's Regeneron-CoV. These two monoclonal antibodies for sure neutralize Delta variant. It neutralizes the Delta variant spike. In other words, these antibodies, we'll use Optimus Prime here. So Optimus Prime will say is the virus, all right? And then this Dasani water bottle is going to be the monoclonal antibody. So the virus is going in here, it's all unchecked. The Dasani antibody marks it. Now it's neutralized because it's bound at the place where it normally binds to the cell. So it can't bind to the cell. And the immune system knows it's there because this is the monoclonal antibody that we've generated. So it gets rid of it. So if you neutralize it and you don't have the virus binding to cells anymore because it can't, it's not going to activate the inflammatory response very hard. And so you don't get that evolution of inflammation, which leads to massive destruction and death in some.
So speaking of, not that you have toys in your office, I'm not suggesting that you sit there and play with that. However, it is bringing me back to my childhood.
Listen, this is the single greatest leader of all time, period.
Okay. That's a whole separate interview. We don't have time for it today. So my question is, though, we do have, a population of certain people. I know there's a lot of different ideas on vaccinations. We'll get to that as well. But obviously children under 12 aren't vaccinated. And although we're not seeing severe reactions to COVID right now, the question is this going to look different over the next several weeks? Can monoclonal antibodies be given to children?
Yeah. So it's 12 and up. So if your child is 12, the answer is yes. If your child's less than 12, it's being studied, I can't say that we can give it to them. I will tell you this. As someone who uses monoclonal antibodies in his practice on a daily basis, I give it because it inhibits certain inflammatory mediators for my severe asthmatics. I also use it for people that have autoimmune lung disease. We also use it in people that have cancers. I can tell you that monoclonal antibody therapies for kids as low as 6 in age have been approved. So in my mind, do I think that eventually, once it's studied and once it's determined that it's safe in kids, like I see no reason as to why it wouldn't be safe in kids in the future. I don't see any reason why it wouldn't be. So I do think that eventually you'll see that. But of course, with kids, everything is heavily scrutinized, right? Everything is heavily scrutinized. You want to make sure you're not hurting these kids. When you look at coronavirus infections in children, most of the data that we have right now is based on the wild type coronavirus, right? Because that's what's been studied extensively, and B117 as well. That's what's been studied extensively. Kids don't seem to get infected very much. My brother, that was called.
Are you serious? I mean,
so kids don't
have
seem...
they have no respect for what we're trying to do right now. Yeah.
None.
Okay.
Zero. Right.
He's not watching? I can't believe it.
No, I have
sorry.
kids at my house.
Okay.
So, yes, kids don't get infected very much based on B117 and wild type coronavirus data, and they're not getting sick very much. It's like 0 to 0.03% present to the ICU. And so because of that, no one's in a rush to give a kid a vaccine. No one's in a rush to give a kid a treatment. But it's not to say that it's not prevalent, because it is. Kids are getting sick. And we see a lot of hospitals around the country that are now full of kids who have coronavirus in the hospital. Do I expect these kids to die at the rate that adults are? No, not at all. Do I expect them to get really sick like adults? No, not at all. When you look at going back to school and you look at outbreaks, right? There haven't been that many outbreaks associated with people going back to school or in school. However, I have 2 or 3 anecdotal examples of people who are telling me that in their respective areas of the country, since their kid has been back in school, there has been an outbreak at that school. Now, the question is, why is that outbreak taking place, right? Is it taking place in areas in which kids are unmasked? Yes, that's for sure. Is it taking place in areas where parents are unvaccinated? So you have to think about all of these things as well. But in my neighborhood, most of the people in this neighborhood are vaccinated. There's not a lot of anti-vaxxers in my neighborhood. It's okay if there are. When we go back to school, I feel more comfortable after reviewing all the data that I have over the last week or two. Sending my kid back to school, yes, they're going to be masked all day, and yes, I'm okay with that.
Interesting. So we're actually have a report we're working on for tomorrow that's going to just bullet point very easily what we know about children so far. And we have to recognize that the data is even sometimes different state to state, because some states call a child someone from 0 to 14, others say 0 to 8. I mean, it's all, so part of this is not part of this. A lot of what we're talking about is about data collection, but it's important to know that when it comes to children, that we actually had to really condense what source we're using and really attribute directly to them, because it's difficult, it's challenging. But overall, what you're saying obviously is exactly right. Very, very low rates of severe cases. Jilly was asking, do vaccinated people who test positive need monoclonal antibodies? Would you give it to someone who's vaccinated?
I would, but I'm that kind of guy.
You're just kind of giving it out. Like, you're like,
Yeah,
monoclonal antibodies, let's go.
I believe in immunology, and knowing that the vaccine is not, 100% effective at reducing severe disease or at eliminating severe disease, I think anybody who's positive should get it. Any aid that you can give the immune system, you should give it. Like,
why do you think we're not talking about this more? Because it seems like something that would actually, we're all looking for, well, how do you have a less severe case? It's been the whole conversation since the very beginning. Why not talk up monoclonal antibodies? Why not make it cheaper? Why not figure out a way? Because right now,
it's free.
Well,
the government purchased all the product.
Well, free for, okay, but someone's paying for it somewhere.
Right.
Okay,
Yeah, we are.
Right. So okay, but I'm just saying, like, right now it's an IV, right, or an injection.
There's IV and sub-Q.
Okay, so why isn't
How
there a
easy
rush
is
to
that?
figure it out though, how to get it, so you could get it at a pharmacy and not go to a hospital?
I can't tell you how many conversations I have had with Regeneron executives. So, small confession, I'm now going to be speaking for the product on behalf of the company.
Well, because you believe in it, right?
Because I believe,
why.
that just came about like within the last week. Obviously, I've been talking about it since Trump got it in November or whatever.
Yeah.
So the what I do want to say is I've spent countless hours talking to Regeneron executives about this. I have spent, even when I interviewed Fauci, I asked him too. That was strategically left out of the interview, but I asked him about this as well. And I don't know.
What did he say?
Don't know. Same thing. I don't know.
What do you think?
He said, God, that's such a great question. Listen, I have a thought, but that thought is not for public conversation. It's more for, we're sitting at dinner and, I'm having a bourbon and your husband's having a bourbon and we're sitting there and we have a conversation like that. That's what that thought is for.
Well, here's what I'll preface that. There's a feeling that there's so much investment in the vaccine and there's so much money and power and all of this kind of wrapped up in this conversation about the pandemic. I know you're a physician and you don't weigh in on politics. I'm not looking to, but I think we should, I just want to articulate that for our audience because it's not like we don't understand that that's taking place. Whether or not those are the undercurrents of why this isn't happening, I don't have any evidence. I'm sure you don't have any evidence either. But what we should know right now is that there is something that exists that looks to cut the severity of the infection. It's something that we can advocate for, ask about, look for, learn about. And ultimately, the consumer matters, right? I would hope. So is there any information that you see or you've learned about that looks like this is going to be something that's more readily available? Can you tell us anything about that?
I can tell you that the ER where I see a lot of patients has changed and become a lot more liberal with giving it out, which I am very pleased about. I do think that in a disease like this, that's newish, right? We know the virus that's causing it. The disease is severe. You've got so many different clinical trials going on and so many different drugs that are being studied to try to help people, to give people options. But in the process of doing that, when a drug such as the monoclonal antibody Regeneron Cove or even sotrovimab, when you see a drug make that much of an impact, you don't just stop everything that you're studying and just go with that one, right? And so I can see why it's happening, but at the same time, you want to make sure that this drug is readily available for any and everyone. When you look at healthcare disparities, this is how they come about, right? If you go to the rich hospital in the area that has the product, you can go and get it. If you go to the poor hospital, they don't have it. I know that one of the hospitals I used to cover, they don't have it. I have no idea why. I don't understand why they don't. They 100% should, and I'm kind of happy I don't practice there anymore. But that is what's frustrating. And that's not only frustrating for me as a physician who advocates for a therapy that I know works, it's also frustrating for me as a parent, for me as a husband, for me as a friend, right? When my friends get sick, and I had a friend recently get sick, she was freaking out. calling me every single day, and I was coaching her and treating her through the illness. But not having that available at certain places is frustrating. So don't get me wrong, like you guys can come up, and I see it here, all kind of conspiracy theories, right? All kinds of about why it's not prevalent and why people, like, I'm with you. Like, I get all that. Like, I'm just as frustrated as you, and so are my colleagues. We are just as frustrated. There are people who are strictly academic. They are strictly by the book. So they go right by the guidelines, right? Allowing a robot to do their job. But that's what they do, right? They go right by the guidelines. I don't. I go by mechanisms. I go by things that make sense. I go by trends that I see in the literature. And so there's a difference there. At the same time, I'm comfortable with monoclonal antibodies. Not everybody is. I use them in my clinic. I give them to people subcutaneously every single day of my life. Like, I'm comfortable with the side effects. I'm comfortable if something happens, I know how to manage it. Like, that's what I do. The people that are in charge of these therapies, infectious disease physicians, emergency room physicians, right? They're the ones that are kind of running it because the emergency room, because they see all the patients first, and ID physicians because it's an infectious disease. They're not comfortable with monoclonal antibody therapy. I do know that, right? They don't use them. They're not as they don't understand them as well, and I think that's probably part of the issue too. And this is not me slighting them or making fun or anything like that. This is just me simply saying that when you're uncomfortable with something, you look for any excuse not to give it. Because
Well, it goes back to your initial point though, about teaching people and not telling them. So if you tell
Correct.
people this is your treatment, just like, we're all human. So if you tell the public this is what you have to do, but you don't teach them, they don't understand the why. I don't understand the why. You do the same thing for physicians. They don't understand the why. They're not going to be comfortable. I mean, they don't want to hurt anybody either, right?
Mm-hmm.
So, well, we'll leave that conversation about why. Hopefully we'll see it more in use. I think we learned a lot about it just now. And it brings up an interesting question from Emily from Indianapolis, Indiana, because she said one of the things she felt is that there's a missing narrative about preventative health. She said, part of the like, this has been so scary. It's like you're just sitting and waiting and like wondering if you're ever going to get infected. And if you get infected, like, what are you going to do? How are you going to feel? So she's like, what about vitamin D? Like, what about actually vitamin D from the sun, like being outside for an hour? What about real basic things? Vitamin C, zinc. What about these things? Is there anything preventatively that you're seeing or that you're advising your friends to do, before they get to the point where they're calling you with a positive test?
I don't think the preventative health narrative is missing. I think it's always been there. I think there are people who are uncomfortable with it because they feel like the preventative health narrative is a little biased, where we want people to exercise and do these things that keep you healthy and look good and all of that. And, then people feel like, well, I want to make my own decisions and all this thing, which, it gets a little weird. I think the preventative health measure has always been there. Exercise is extremely important. If you look at exercise in terms of the immunology of it, what exercise actually does when people do exercise, like it's like 30 minutes of cardiovascular, 20 minutes of cardiovascular exercise a day, is those people get less infected. I think it's because of that blood flow that happens. And when you have blood flow, you have lymph flow. Lymph is where your white blood cells reside and where they travel, right? That's the freeway system of the white blood cells, right? It's like taking I-5 or I-35 where you are. That's what the white blood cells use to travel. So when you're running and when you have cardiovascular exercise, they're going all around your body surveying the field. So that's a good thing. That's why exercise is good for you. In terms of the products that you mentioned, vitamin D, vitamin C, zinc, what are they? So what these products actually are is they end up being cofactors in reactions in your body. They allow your body to function optimally. They allow your body to function efficiently. I hesitate to use the term therapy because they are not therapies. They are more of allow your body to have the optimal level or the optimal amount of vitamin D, vitamin C, and zinc to allow your white blood cells to work perfectly. When you look at the white blood cell in particular, there's a vitamin D receptor on the white blood cell. Those are the cells that fight infection. What does it do? It essentially allows the white blood cell to work efficiently. It gets in, it gets out. The problem with disease, first of all, is that people think that pathogens are causing disease. Pathogens, in a sense, are activating disease. They are leading to the congregation of white blood cells in end organ areas. And when you have that, that's disease, and that's the problem.
So supporting the white blood cell is important.
Correct.
Okay. Just wanted to
Make
and
it
by
simple.
the way, I'm really like impressed by your highway knowledge in Texas with the I-35. I was like, that was really good. I didn't know anything about I-35 until I moved here. We're getting a lot of questions. Carrie was asking and Gina's asking, just going back to monoclonal for a second. They're just asking if there's any side effects to monoclonal antibody treatments.
Mm-hmm. So with any monoclonal antibody therapy, you have to worry about the immune system becoming activated because of the presence of the monoclonal antibody and the things that might get activated. And so you can develop things like anaphylaxis, which is low blood pressure. Although I don't think we saw it at all in any of these trials. You develop things like rash, you develop things like urticaria. These are common side effects. Rarely.
What's urticaria?
Urticaria is like a raised inflammation under the skin.
Okay.
Like we call it chronic idiopathic urticaria, CIU. But it's all as a result of probably basophils and certain white blood cells that are congregating in the area. But it's very, very rare. And in these monoclonal trials, there weren't really any side effects for the drug.
Have you seen any of those side effects?
No, I haven't seen one.
Okay. Have you seen any side effects?
Not in these therapies, but in my asthma therapies, yeah, I have.
Okay. Have you come up close and personal to any adverse reactions from the vaccine?
You know, I'm so happy you asked that question. Here's why I'm happy you asked that question. Again, just a reminder, guys, I'm a pulmonary critical care physician, so I'm going to take care of people who are actively dying and who are really, really sick. And I'm also going to take care of people in my clinic who have lung issues or any kind of reaction, right? I haven't seen one. I haven't seen a serious reaction. I haven't. Not in the hospital, not in my clinic. I've seen people develop rash. I've seen people say they have a headache. Sorry, my leg is like cramping. I've seen people say they have like a headache.
Do you need to stretch it out while you're?
That's why I was sitting up. But I have not seen people have a serious reaction. I just haven't. And I know the VAERS reports, and I get it, and I understand it, and I see it, and I know people are worried about that. Trust me, I'm worried about it too, right? I got 2 kids that when the vaccine's approved, they're getting it. But I just haven't seen it. So since I haven't seen the reactions at that level, I got to think that my experience counts for something. So I'm not saying they don't happen. I think they do. I haven't seen it.
Okay. I know you didn't want to get too far into the conversation about, reasons monoclonal antibodies are available or not. So we're not, but we are going to go into something that's actually pretty controversial, totally lighting the internet on fire. Mm-hmm. I sent you this video. I've been sent this video about, I don't know, a few hundred times. Pamela's like, can you please comment on Dr. Dan Stock's presentation on YouTube in Indiana? This is a functional medicine doctor, made about a 6-minute presentation in front of it was a board, right? And he kind of goes through a list of reasons why current policy about the new coronavirus is wrong. And he does it in a very academic way. And one of the things we could pick apart, we could talk about a lot of different sides of it. I'm totally open to how our audience would like to attack this, or what you all, if you've seen it, what you're thinking of. If you haven't seen it, you're going to see it. Okay. So I wish I could play part of it for you. I was trying to do that, but I couldn't figure out how to do it while we were live. There is a point that he makes about the vaccine, which is that these sorts of vaccines, he's saying, that are available now for the new coronavirus can actually enhance our body's reaction, right, to it, that somehow it could actually make us sicker. And that what we're seeing right now in the country is, again, proof that the vaccine isn't really working. He also mentions that we shouldn't be seeing this sort of explosion, if you will, of respiratory virus during the summer, that really this shouldn't be happening. What did you find most interesting about the video, or if there's one point that you would like to address, Dr. Rutland, what would it be?
There are several things about the video that I found interesting. The first thing I found interesting about the video is that this guy clearly is an excellent communicator and he's an excellent teacher. There is no doubt in my mind that whatever he wants to teach, He will get it across to his audience, period, end of story. The guy is excellent at communicating. No doubt he has those skills. It just so happens that he's wrong. And that sucks, but he's wrong. A functional medicine physician, they're valuable to our society. And what they essentially study is they study a lot of cell communication. They don't really study pathophysiology of disease. They don't really study, like an example would be like, if you're sick and you're dying, the functional medicine MD is not rounding in the hospital on you, okay? If you're sick in the hospital, the functional medicine doctor is not rounding on you in the hospital.
But isn't the
okay?
functional medicine doctor, like their focus is that no one gets into the hospital, that they're going to help you be as healthy as possible so that you don't wind up there?
Yeah, their focus is to make sure your body functions efficiently. I respect that completely. But he's wrong. So what he is referring to, everyone, he says vaccine dependent enhancement, right? What he's talking about is antibody dependent enhancement. All right. So we talked about what an antibody is. Basically, what happens is as a result of the production of an antibody, secondary to whatever antigen, whether it's a pathogen or whether it's a vaccine, the antibody binds to that pathogen in such a way that makes that pathogen stronger. It allows it to enter the cells easier. It allows it to infect easier, okay? That is antibody-dependent enhancement. Have we seen it before? We've seen it before. We see it in dengue virus, in the virus in general. People who get the dengue virus, once their antibodies are created, it does enhance disease. That's one. We've also seen it in one measles vaccine that's not used. We've also seen it in an RSV vaccine that's also not used. So this concept can happen. Now, remember what I said earlier? We've been studying SARS since at least 2003 when we had that first epidemic in China, okay? When we were first making vaccines towards SARS, we were using the nucleocapsid protein as the protein that we were going to vaccinate people against. So the body would recognize nucleocapsid protein. Now, what they discovered, at least in studying nucleocapsid protein, is that did lead to antibody-dependent enhancement. Hence why we don't use it anymore, and now we're using the spike protein. So now the question is, are we seeing antibody-dependent enhancement in people or animals that have received the vaccine, right? Now, in animals, chimpanzees, we gave them the vaccine, and then we re-exposed them to virus. This is an environment in which you would have antibody-dependent enhancement. They didn't have it. In human trials, we also have no examples of antibody-dependent enhancement. We did not expose people to disease after we gave them the vaccine, right? Because, I mean, who's going to do that? Oh, hey, I got the vaccine. Let me just go put you in a room full of coronavirus and see what happens. Like, we're not going to do that. Nobody's going to volunteer for that. So we don't have it. It just is something that's untrue, and it doesn't happen.
What would it look like if it was true? Like, what would we be seeing if that was the case? Would we see it already, or is it something we wouldn't see for a couple of years?
So let's think about this. If we know that 30% of adults, their common cold is caused by the coronavirus, we would see it there. So we would see it every winter, right? Every winter we would see people that get coronavirus, they develop those antibodies, and then boom, they get sicker. That doesn't happen. So it just doesn't happen in this condition. It doesn't happen in this disease. In terms of people who are vaccinated, if you saw antibody-dependent enhancement, right, then I would see 80%, 90% vaccinated in the hospital. Like that's not what I'm seeing. So again, I understand the concept, and the concept does exist, but in what he's articulating and talking about, he's just wrong. That's it. Mm-hmm. He's very eloquent. He's very good. I'm sure he's very smart. But in this situation, he's just wrong. And I've posted it on my story in Instagram. If you swipe up to my last 4 stories, I put it on the last 4. What you're going to see is you're going to see this article on antibody-dependent enhancement written by Derek Lowe, one of the best scientific writers I've ever encountered. And he has all of the references within that article. And you can read all of the references, and then you'll come to the same understanding that I came to, which was antibody-dependent enhancement as it pertains to the vaccines that are EUA right now does not happen.
So part of the issue that we're confronting with the vaccines is that They're still under emergency use authorization. It's not necessarily a new technology to science, but definitely to us as a consumer, as a health consumer, an mRNA vaccine. And one of the other questions that our audience has been about the ingredients of the mRNA vaccine specifically. There's been some different theories that have popped up this week, not particularly on this video that you're mentioning, which the functional medicine doctor, but another one that's been circulating about a former Pfizer employee that's alleging that there is a certain chemical, graphene, I believe, and I don't know if it's a chemical, if that's the precise. It's interesting. I believe we did a story on graphene. I'm going to look it up while we're talking. Let me look it up while we're talking, doctor, because I think it's been used in a couple things that are unexpected. But because it's not like you go to the grocery store and you see a list of ingredients on like a pack of cookies that you're buying. You kind of think you know what's in it. And there's a question about this vaccine for some, again, about what exactly is in it. How when a patient comes to you with a question like that, how do you address that? Especially because you say, once this is available for your children, you'll look to get them vaccinated.
Yeah. It's really based on two things. One is the ingredients that they tell me. And then the other thing is that, is your experience. So I've had plenty of people who've gotten the vaccine that are around me that are just fine. When you listen to this lady talk, and it's weird that, her whole affect during that interview, she was very emotionally believable, but also kind of like, I don't know, it was weird. Like it also felt like an out of body conversation. It was just kind of weird when I watched it. But I listened to her. And one of the things I listened to was when she talked about the lipid nanoparticles in the vaccine. And she said that they generate an electrical charge. So then that they can control your thoughts because they generate an electrical charge. So somehow she went from electrical charge to controlling your thoughts, which I thought was quite interesting because she didn't actually teach as to how that happens or why that happens. She just kind of said that, and it sounded emotionally believable. However, the lipid nanoparticles are actually present because that's what your cell is made out of. The circle in which your cell is residing in, that circle is made out of lipid nanoparticles, right? The likes dissolve likes. So for the vaccine to get inside your cell, it has to have lipid nanoparticles that surround it so it can diffuse inside your cell. So I can explain that. She can't explain the mind control thing, charge and whatever. But, I appreciate her efforts and I understand her questions with ingredients. It's not the first time that we've been told something's in it and may not be in it, whatever. I tend to believe science on this one, right? There are lots of skeptical people out there, especially academics, who would look into this and they would study this, and they haven't said anything that would contrast what the big pharma companies are telling us are in the ingredients.
Okay. Graphene, by the way, this is what we covered. I was like, I knew it from a story that we did at Sparner News. Graphene can conduct electricity. And it's actually, researchers were using it to try to figure out if they could create hair dye with it, because it would be a way for you to dye your hair. Listen to this. This is true. This is a true story. This is the sort of stories I was able to explore before we were in the middle of a pandemic. It's really kind of interesting, like fascinating things that researchers look at. So listen to this. It's a chemical that they were using, this non-toxic, antibacterial, anti-static. It was a way to dye the hair so that your hair would stay dyed longer. But there may be a way to conduct electricity with it. I'm going to have to pull it up and post it. I'm not making this up. I know I sound like maybe I'm pulling in different theories. No, this is a real story. It was from Northwestern in 2018. I've been doing this too long. I was like, I totally know graphene. It was used in hair dye.
People are saying that I don't know the ingredients. I do know the ingredients.
Yeah,
it's sugar. Yeah, it's sugar, lipids, mRNA, some acids, some salts, and some stabilizers. That's what's in this vaccine. It's actually one of the purest medicines like ever created, to be honest.
Is there anything weird there that you don't want to have in your body?
No, there's nothing weird there.
Okay. All right. I'm not a guest. That's her name. Not a guess. It's a beautiful Persian name. She was telling me she's in the San Diego County. She recorded a video for me, actually, Dr. Rutland. And again, I can't play it, but she was saying that she had an interesting question. She's fully vaccinated, and in her particular county, she can wear a mask or not wear a mask. And she was saying, like, as a vaccinated person, does she really have to wear a mask? She's like, at a certain point, everyone has to make up their own mind about masking. You know, are we just going to be in this state forever of mask on, mask off, mask on, mask off? Like, if you're vaccinated, how critical is it for you to do that?
So here's my strategy with masking. If I'm going to be in an area in which I don't know these people and there's a whole bunch of people around, I wear a mask. So like example, like I go study pretty much every day. I'm going to study it right after this. So I'm going to go into Starbucks. I'm going to wear my mask in Starbucks. I'm going to go order my coffee. I'm going to wear my mask when I order the coffee. I'm going to go sit down at the table that's a lot of feet apart from everybody else. And I'm going to take my mask off and I'm going to read. When I go to the grocery store, I wear a mask. When I go to Laguna Beach and I'm walking to the beach from my brother's house, which is right across the street from the beach, I wear a mask. When I get to my spot on the beach, I take it off because I'm with my family and they're all vaccinated. So I don't know, I just try to use, this thing called like common sense. So I just try to do things that like make sense in my mind. That's what I do, right? And people say, oh, well, masks only protect you for like 30 minutes. And I'm like, I'm walking by somebody that has coronavirus for seconds. It takes me 2 seconds. Like, so I don't know what you're talking about. Like, it's not like I'm kicking it with the person, right? So, and then I always screen for where I'm going and who I'm with. Like, if I'm with somebody that's not vaccinated, usually like, I'm not going.
For now, that's how you feel.
Yeah.
Okay. I want to get in a couple, it looks like we have some more questions about vaccine ingredients. So I want to pull those up. I know Instagram will cut us off at an hour. So I know you've been so great sitting here with us on all of this.
Is it really? I didn't think they cut us off at an hour.
They do. They give you like a little countdown clock. It kind of makes my heart start pounding. So I think it's like they're going to get the hook. But if anyone does have questions about ingredients when it comes to the vaccine, I'm happy. We're happy that Dr. Rutland is here, and let's make sure that you guys get your questions answered on this. Let me see real quick here. Samantha has a great question about discussing the benefits of natural immunity and memory cell function. We talked a lot about antibodies. Dr. Rutland, as I'm seeing some more questions come in, can you talk a little bit about memory cell function? I know that's kind of your thing.
Yeah, whenever somebody, I get like tickled every time somebody says memory cell. It makes me feel like great. So the way that your body works, again, is you're exposed to antigen. Antigen gets cut up into little pieces, presented to your immune system. Your immune system takes it, makes cells that can bind to this antigen now, these little new pieces of this antigen. And then in the process of doing so, they want to remember how to do that in case they ever encounter this pathogen again, right? And so then the memory cells are going to be able to communicate with B cells and other T cells to generate the molecules that are necessary to bind this antigen again. Like if you look at a bee sting, like you get stung the first time, there's no issue. The second time, you might develop a severe allergy, right? And it's probably because of the memory cells that remember that antigen and respond to it really quickly. So, we see it every single day. When you look at memory cells and SARS-CoV-2, yeah, they're still present 12 months later in the bone marrow, which is great, right? Same thing for the vaccination though. Like when you get the vaccine, memory cells do remember it up to now 8 months later. So yeah, memory cells are vital and they're very important.
So how does that compare with if you have a natural infection that you get, how does it compare in your mind to the vaccine? When you're looking at this sort of competing immunity, and again, the lines are drawn between those vaccinated and those not. And by the way, I saw one comment where I'm picking out, these were 2 viral videos that came up this week. And because you might encounter them, I wanted to pull like the main themes from these viral videos so that you had some backgrounds. Mm-hmm. But that's why we're addressing it. We don't think like everyone who's not getting vaccinated, believes that the ingredients are bad. There's lots of reasons why people may not want to get vaccinated. And we've talked a lot about them, but I'm curious what do you think about this competition between the vaccinated immunity and the natural immunity?
First of all, it's not a competition. It is they work together. When you are naturally infected, remember what I said, you're naturally infected and you create an immune response that can recognize every little piece of that virus. membranous, envelope, nucleocapsid, spike, non-structural proteins, open reading frames. That's what you're doing with natural immunity, is your immune system is learning how to recognize many different pieces of that virus, okay? Some of those pieces really don't matter. So your immune system may quite frankly be wasting its time, but it doesn't matter. You're gonna recognize that whole thing. The spike protein matters most because that's the protein that binds to our cells. So with vaccinated immunity, you're recognizing different pieces of the spike. Here's how I think about it. If you have an entire virus to recognize and look at, okay, what's gonna happen is your immune system is gonna recognize a whole lot, but diversify a whole little. It can't diversify as much. When you are the spike protein and it's just the spike protein that you're being immunized against, your immune system now has the opportunity to create diverse types of spikes, diverse types of antigens, and actually create cells that recognize diverse types of antigens. That's why the variants are covered with the vaccination. Some better than others, some less than others, but in general, that's why the variants are covered. So it's not that they're competing. When you are allowing yourself to be exposed to the virus being naive and not vaccinated, you're also risking severe disease and death. Whereas with the vaccination, that usually doesn't take place. You're not risking severe disease and death as much. So that's just the difference. I appreciate and respect what natural immunity can do, but it doesn't mean that I deny the vaccine. Okay, natural immunity, I think, is wonderful. And I do think that people who are infected and who have had the infection, I do think checking spike protein antibodies, nucleocapsid antibodies, whatever, T cell tests, I do think that if they're uncomfortable getting the vaccine, I would listen to them and I would say, okay, guys, I think there's a situation here where we allow them to participate in life like a vaccinated person would, because they still generate the appropriate antibodies and cells. But I also understand the message behind we need to get everybody vaccinated. So I think that explaining natural immunity is easy. I think that explaining vaccine immunity is easy, but they're not competing with one another. Mm-hmm. If you look at hybrid immunity, people who have been naturally infected and then people who get the vaccine, they have a much more diverse response to spike protein, which is great. And then they get that greater response to spike protein because the immune system gets to concentrate just on that instead of concentrating on the entire thing. I hope that makes sense.
It does make sense. I mean, I just think it's just good to talk about in a way that you're not, that people don't have to be criticized when they're trying to make decisions for their own health. And especially if they have a previous infection and we don't know what that previous infection might look like for them. Maybe it's not something that they're going to turn around and get a vaccine for. And if they're not put down, I mean, that's the thing. We started this conversation about tone. You know, it's the tone that comes with all of this conversation that it's enough to make, you know, obviously turn off someone that's just looking for some reliable information and some honest questions about a place that we've all never been before, which is in the middle of a pandemic with a new coronavirus that none of us have ever dealt with and some new ways to treat it, like some of them that you mentioned. You mentioned, Dr. Rutland. So we have a bunch more questions, and I'm sorry we're not going to be able to get to them all. We have, by the way, a whole interview. I've obviously talked to Dr. Rutland a lot about natural immunity, but I have a whole interview as well on natural immunity later this week, so I want people to know that too. Let me just see if I can get one more quick one, Dr. Rutland, before we leave. Anything, well, let me just hand it off to you. Anything in general, Dr. Rutland, that you think is really important for people to know at this critical point in the pandemic?
If you're naive, meaning you haven't been infected,
not naive, like we're not saying you're naive here.
Right.
Naive, your body.
Yeah, your body's naive. You haven't been infected. You don't have the vaccine. If you're around somebody who has SARS-CoV-2 or one of your friends got it, be wary of your symptoms. Let your physician know what's up. Know where to get monoclonal antibody therapy if you need it. I think that is the most important thing. I think the one thing that you're noticing with this, for people who are non-believers in the pandemic and non-believers in this causing issue, is this. When I was 8 years old, Janelle Stockton, who lived across the street from me, got chickenpox. My mom said, go over there, take a little black booty over there and go get chickenpox. So I went over there and I got chickenpox and I had it. no big deal. I itched for like 3 or 4 days, whatever. That is a condition in which support and reaction to somebody else having chickenpox, like that is a condition where you're not tripping. You're going to go get it, right? It's fine. You don't see anybody doing that with SARS-CoV-2, and nobody having the SARS-CoV-2 party. So it's something to be taken seriously. Nobody's like, oh, hey, come over here and get SARS-CoV-2. Let me send my kid over there to go get SARS-CoV-2 to go get infected and see what happens. That's how you know it's a serious infection. So please just understand that it's a real thing. It's what I'm seeing in the hospital. My experience counts for something. I don't mind if you don't believe everything that you hear. I'm okay with that. Ask questions. Try to understand why people are articulating certain things. And I want you guys to question the misinformers or the people who come out with these videos as much as you question us. Me.
Interesting. Yeah. Well, I appreciate your experience. How do we pick people to talk to? We want people that have real experience treating this in a hospital. And we also want to talk to someone that can explain things in a way that we can understand. I know there's like a bazillion more questions, so we're going to collect those. Hopefully you'll come back again, Dr. Rutland, in the shoe side.
Are we doing this every Tuesday?
I would love to do it every Tuesday if our audience would like it. And I think it would be really great. And I'm happy to bring in your friend. I'm happy to bring in more voices too.
Yeah.
And I think it would be great. If you're down, I'm totally down. And I think the more we can do this, and if people like want to comment on this video, like what they would like the focus to be next week, maybe we pick a theme, because there's so many different things that we could all tackle. And so it might be good to say, hey, we're going to do 30 minutes on the ingredients in the vaccine, for example. And maybe we could go through each one. I would think that would be super interesting. So.
Yeah, somebody mentioned PEG, polyethylene glycol, which is in like all the food that you eat. So relax.
Is that in the vaccine?
Yeah.
Is that bad though? Just because it's in the food that I eat doesn't mean it's good.
Sometimes, yeah, but sometimes it can cause allergy, like it does in kids too. It can cause food allergy, activating basophils and mast cells. You never know who that's going to happen to, but it's there.
Okay. Well, thank you, Peg. Now we all know. All right, guys. Thank you so much for your time. Dr. Rutland, thank you so much for your time. I'm going to just do like a little like prayer that we can save the video, that nothing interrupts this.
Okay.
And I'd love to do it next Tuesday. So if you're game, you don't have to wear a suit if you don't want to, but I mean, it does look nice. So if you
Hey, listen, sometimes you got to dress for the job you want, not the job you got.
I get it. Thank you, Dr. Rutland. I appreciate it. All right, guys. Have a great day. We'll talk to you later. Bye.